Hi, hello, good morning, good afternoon. Can you hear me okay and see my screen?
See, yes, perfect.
Okay, thank you, Christina, and thank you for the invitation to be part of this. It's really wonderful to be able to participate in your most incredible meeting from across the sea in a different part of the world where we in the throes of a major third wave from COVID and people aren't really thinking about TB, but of course we all know how important TB is in children's. So thank you again for inviting me. And today I'm going to talk about the epidemiology of childhood TB in the context of pneumonia and the impact of new diagnostics. The talk will cover a brief description of the burden of TB in children and the association with pneumonia, limitations of current diagnostics, and it's going to focus on advances in microbiologic diagnoses, specifically improved sample collections and the role of, the role of expert ultra, and I'll briefly touch on other new diagnostic methods. So to begin with TB in numbers, okay? Almost 10 million people have TB disease in 2019. This is from the latest global TB report. Around just over 8% of those HIV infected, and almost 1.2 million people dying from TB in this period. As many of you know, this has probably been increased substantially through COVID because of people being reluctant to access TB services, lack of ongoing treatment, and a confusion or misdiagnosis, lack of diagnosis of TB through the COVID pandemic. And the estimates are that TB control programs have been backset by around a decade due to COVID. But at the time of this report, children were estimated to account for around 12% of cases, which translates into about 1.2 million cases. Sorry, I don't know why this is jumping, it's very sensitive. And predominantly in Southeast Asia and Africa, with 8 countries containing 2/3 of the burden of disease, primarily India, China, Indonesia, the Philippines, Pakistan, Nigeria, and Bangladesh, as well as South Africa. And overall 30 high burden countries accounting for around 87% of the burden. And this reflects both the childhood population in these countries and the adult population, as well as the prevalence or of TB in these populations. And so if we look at TB incidence by WHO region, again from the global report for the different regions, just to make one point, and you can see the dotted line here is the 2020 target, and you can see that while rates are coming down here, shown in green across these regions, in red is the rates for HIV infected people, you will see that almost no region has achieved the target. So globally, we are really far behind in terms of achieving the target for reduction in TB incidence rates. And as I said, COVID has really jeopardized this further. Now, if we look at the number of cases that are in children, you can see that the pyramid looks like this: in purple, females, and in green, males, with the predominant burden in the 15 to 34-year-old age group, which is also important for us because certainly adolescents fall into this age group, and we all know about, my apologies, we all know about resurgence of TB in adolescents. But in this age group, I think we have to be a little circumspect about these numbers. And if you look at this mathematical modeling study that estimated the burden of childhood TB in 22 high burden countries, these investigators estimated that around almost 500,000 cases, 500,000 children developing TB per year. Well, this was based on 2010 numbers, but alarmingly, why am I jumping like this? Only a third were notified. And I think this raises important questions about how accurate these numbers are, because we know these numbers depend on accurate diagnosis. this seems to be doing its own thing. I'm not even moving it. Sorry, my apologies. And we know that diagnosis can be challenging in children. And I think this has been made even more difficult because we know that TB now is an important cause of acute pneumonia in children in high TB burden areas. There's a very large burden of pneumonia in children. Almost around 800,000 children under 5 years of age die each year. And in this meta-analysis of children with acute pneumonia, almost 8% had culture-confirmed disease in acute pneumonia. And we know that, you know, it's rare to be able to confirm TB with culture in children. So I think this is a very conservative estimate. You could probably multiply it by 3, more than 20% of cases having TB of those children with acute pneumonia. And it begs the question of how many cases of TB we are missing, particularly in the context of childhood pneumonia. So let me show you a little more evidence for TB as being a major pathogen in pneumonia. And this is from the Purge Study. Many of you will be familiar with the Purge Study. This is the Pneumonia Etiology Research for Child Health Study of severe and very severe pneumonia of children hospitalized in 9 study sites across 7 low middle income countries: Bangladesh, Thailand, Gambia, Kenya, Mali, South Africa, and Zambia. And here are the list of pathogens, top 10 pathogens for each of those sites. And what I've put in the square box is you can see that MTB features in every single one of these sites as one of the top 10 causes of acute severe pneumonia in children. And you can see in some sites like the Gambia, like Zambia, like South Africa, it's in the top 5. Although across the sites, RSV was the most common cause of severe pneumonia, accounting for around 30% of cases. And if you look at M. tuberculosis as a pathogen in all the cases, or in cases stratified by age under 1 year or over 1 year, here are the odds ratios, or stratified by severity, by severe or very severe, you can see it doesn't matter. M. tuberculosis is strongly associated, accounting for the etiological fraction, approaching around 8 to 10%, so quite consistent with that meta-analysis that I showed you, whether it was in very young children or older children, or severe or very severe pneumonia. I don't know why this seems to have a timer on it, it's doing its own thing, so I'm sorry, I'm going to have to manually go backwards and forwards. So I think strong evidence for M. tuberculosis as a pathogen in the context of hospitalized severe or very severe pneumonia. I want to show you a little more data, and this is from our birth cohort study in a peri-urban area outside Cape Town. And this is the Drakenstein Child Health Study. And in this study, we enrolled pregnant women, followed them through pregnancy, birth, and then continue to follow their children until they are at least 5 years of age. And every time a child develops pneumonia, we're able to investigate for pathogens and also look at risk factors for those different pathogens, as well as look at the impact of pneumonia on chronic lung disease. And this is the study site is in a poor area. I'm sure that many of you in Latin America are familiar with the kinds of poverty that some of our participants live in. We have a fairly high prevalence of HIV in mothers, around 22%, but almost no HIV in children because we've got a strong mother-to-child prevention program. But crowding, low socioeconomic status, no running water in many of the households, and communal toilets for some. And so here, similar to Purge, we found RSV, the commonest cause of pneumonia, in around 23% of cases with an odds ratio of 8. So these are the cases of pneumonia, and these are matched controls, age-matched children in the cohort who did not get pneumonia, matched to the case. And Bordetella pertussis and non-typable Haemophilus, were also bacterial causes, and these were the viral causes. And there was a median of around 5 organisms detected at the time of pneumonia. But what about TB? And here I'm showing you the incidence of TB during the 5 years. stratified by age. So this is 6 months, 12 months, and up to 5 years, 60 months, for 3 different categories of TB diagnosis. The light orange is microbiological diagnosis. The more deeper orange is radiological and or microbiological diagnosis. And the very deep orange is clinical diagnosis, radiological or microbiological. And so what you can see is there's a trend to increased numbers of children diagnosed with TB, whatever of the 3 definitions you use. And this blue line is the tuberculin skin test positivity. And you can see that that also increases with age. And we were amazed to find that the incidence of tuberculin conversion was around 11.8% annual risk of infection. That we weren't amazed to find, that has been reported before from Cape Town. But the incidence of TB was extraordinarily high, 2.9 per 100 child years of the deep orange, any TB disease. And if you looked for microbiologically confirmed TB, 0.7 per 100 child years, translating into 2,900 cases per 100,000 or 700 cases per 100,000 population. These are the highest reported rates in the world, I think, for TB, for confirmed TB diagnosis in such young children, despite the fact that there's no HIV amongst these children and that none of these children are severely malnourished because they're very carefully followed in this birth cohort, and we intervene if they get obviously start to develop malnutrition. And what did we find? We found a very strong relationship between lower respiratory tract infection and TB, tuberculosis. And if you look, for example, for microbiologically confirmed disease, a 9-fold association with lower respiratory tract infection, very, very high association, whatever whatever definition of TB you used. Tuberculin skin test conversion was also associated with TB disease, and INH preventive therapy was protective, as one would expect. And there was also a relationship between recurrent lower respiratory tract infections. So here you can see the hazard ratio for the association of TB with lower respiratory tract infection for 1 lower respiratory tract infection, 2, 3, and up to 5. And you can see that the hazard ratio increases as the number of lower respiratory tract infections increase, showing, confirming that association with lower respiratory tract infection, and perhaps indicating that in fact TB was not picked up in these earlier lower respiratory tract infections. We may have missed the diagnosis then. So I think the evidence is really increasingly strong that TB is a pathogen in acute pneumonia. Yet, if we think about our TB programs and we think about our childhood pneumonia programs, they're 2 separate programs. There's one algorithm for childhood pneumonia and there's one algorithm for childhood TB. And in our country, for example, they're even in separate clinics and different health services. And I think as pediatricians and child health specialists, we need to really think very carefully about integrating these services and about considering TB in the context of childhood pneumonia, particularly in high endemic TB settings. So let me turn to the limitations of current diagnostic approaches in children. And we know that clinical diagnosis is fraught. And here, for example, is a study that looked at the proportion of children diagnosed with TB using 9 different scoring systems, shown here. If you used the MASA scoring system, around 7% of children would have been diagnosed. If you use the Osborne's scoring system, close to 90% of children would have been diagnosed. And then with these other scoring systems, there's a whole lot of variability. So where is the truth? These are all the same set of children with very, very variable diagnostic yields using clinical scoring systems, which largely rely on symptoms, tuberculin skin test conversion, and X-ray changes. This is a systematic review of clinical diagnostic systems, 40 studies, only 16 were validated against a gold standard. And the problem is there's wide heterogeneity in systems, in the definitions used. For example, what is the definition of a TB contact? In the gold standard used, very few, for example, use microbiological confirmation in the kind of disease against which they are evaluated. For example, pulmonary TB as opposed to extrapulmonary TB. So, point systems are quite widely used, but very few of these are validated against culture. And in fact, only the Brazilian Ministry of Health scoring point system is validated against culture, and that actually had high sensitivity and specificity. But for all of these, there's also lower sensitivity in HIV-infected children, and often lower sensitivity in very young children and in malnourished children, the exact patient population in whom diagnosis is especially crucial. What about radiological diagnosis? And here, well, if you have some of the cardinal radiological findings, such as expansile pneumonia shown here with compression of the left mainstem bronchus and the trachea, in the context of a child who's had a TB exposure or has a tuberculin skin test, that's very helpful. A miliary pattern on X-ray is of course almost pathognomonic. And then adult type cavitary disease, more common adolescent TB, is also often quite suggestive. But much more common than that, the diagnosis of TB in children rests on this sign of hyaladenopathy. And here it's shown very well. You can see on this lateral, the so-called donut sign with this round ring formation around the hilum, but it's very rarely that clear. And if you look at how often there is agreement for the sign, there is a wide inter and intra-observer variability in the interpretation of this key sign. And so, for example, if you look at the interpretation of chest X-rays, and these are three reviewers looking at, experienced reviewers looking at the same X-rays, you can see reviewer 1 says 11% of these X-rays are suggestive of TB, whereas reviewer 3 says 51% of these X-rays are suggestive of TB. Again, wide variability. Can we improve on radiological imaging as a diagnostic strategy? And there have been improvements in terms of using ultrasound. Sorry, I really wish this would not be doing its own thing. Chest ultrasound to look at mediastinal nodes, as well as a protocol that looks for extrapulmonary TB called FASH, and chest MRI. Now, this is point of care ultrasound looking for extrapulmonary TB, and this looks. This is a study that we did in 232 children, quite young, a median age of just over 3 years. And you can see this looks for abdominal lymphadenopathy, splenic microabscesses, and hepatic microabscesses, as well as pleural effusion. And in fact, we were surprised to find almost a third of children who we thought had pulmonary TB in fact had extrapulmonary findings. And these were largely abdominal lymphadenopathy, splenic microabscesses, which were associated with confirmed TB. The other useful thing about ultrasound, was that within 3 months, you can follow up children, and these ultrasound findings resolved by 3 months with treatment. So we think that ultrasound, and this is fairly easy protocol to use, doesn't require a radiologist, you know, it took about just a couple of hours of training of pediatricians and actually medical officers to do, and was we found to be very useful in terms of finding extrapulmonary TB, which obviously has implications for treatment, and also enabling follow-up of children to see that treatment in fact was working. Ultrasound can also access the mediastinum, and this we found really only is really only feasible in older children with flexion of the neck. And here it's more difficult than the protocol that I've just shown you, which is for extrapulmonary TB. But it does allow you to see mediastinal lymphadenopathy through the suprasternal notch. What about MRI? And so here, for example, is an X-ray, and you may say, well, is there a hilar node or isn't there? And you can see on MRI, it's much more clearly shown, again, there. And what we have found is that on T2 weighted images, in fact, you have enhanced node intensity, a very high signal, and which we think is pathognomonic for TB. And so this, we think, is particularly useful in children where you definitively want to diagnose hilar adenopathy. And also, we've been able to do very rapid MRI, which does not require sedation in children. Sorry, this, of course, this is limited by the availability of MRI, the cost, and so on. But for example, in TB diagnostic studies, this can give you another gold standard with these enhanced nodes on T2 weighted images. But let's turn to the crux of where I think we should be putting our focus, and that is on improved microbiological diagnosis. And here we'll focus on improved specimens, for example, oral or tongue swabs, nasopharyngeal swabs, induced sputum, stool. So let's look at oral swabs first. And unfortunately, I think there was a lot of hope that oral swabs or tongue swabs would give us an easy to collect sample with high yield. But you can see here, this is PCR on oral samples, only providing a sensitivity of 30%. If you do 2 oral swabs, you only get up to a sensitivity of 43%. This was using an in-house PCR. We've subsequently repeated this using Expert Ultra, and the results are not much different. So unfortunately, oral swabs, tongue swabs really don't have adequate sensitivity to meet WHO criteria for a diagnostic test. What about stool, which is another non-invasive sample? This is a meta-analysis of Expert on stool, and you can see overall the sensitivity is not too bad, pooled sensitivity of around 67% with a very high specificity. Interestingly, the sensitivity is higher in HIV infected than uninfected children, but but the studies that have compared induced sputum to stool consistently report a higher yield, substantially higher yield on induced sputum compared to stool. So induced sputum still remains a better sample than stool when using Expert. So let's turn to induced sputum, and just to make a few remarks about this to start off with. This was quite a large analysis of many induced sputums, more than 2,000 induced sputum, around 1,270 induced sputums procedures, of which around 20% turned out to be culture positive. But remember that amongst these children, there are children without TB. So if you look amongst those who were clinically diagnosed and treated, the culture yield was around 50% of children who were treated for TB, in fact, were culture positive. Children were young, around 2 years of age, around a fifth were under 1 year of age, and the induced sputum was well tolerated. The most common side effect was epistaxis, and there was very little, there was no hypoxia, in fact. Importantly, a second induced sputum gave an incremental yield of around 15%, and this was by culture. And this is an important theme that I'll return to, the need for repeated samples in children. And another important point is that induced sputum was obtainable in almost all children. There's almost no child in whom induced sputum could not be obtained, and there's no younger age in whom induced sputum cannot be obtained. So even in neonates, induced sputum can be safely done. Now, what about, how does expert on induced sputum function? And here, this is a meta-analysis of, and I just want to show you how many studies there have been in more recently of induced sputum. You know, obviously my team have been doing induced sputum for a long time, but it's really incredible to see the proliferation of studies using induced sputum in children. And you will see that that they show moderate sensitivity, around 60, 65%. This is for one induced sputum, and high specificity. And if you look at nasopharyngeal samples down here, lower sensitivity, around 30 to 40%, but high specificity as well. And this is for expert. Now we know that we have now seen an improvement on expert in terms of expert ultra. But just before I come to that, to return to the theme of needing repeated samples, this is a Tanzanian study that looked at 1 sample in green, 2 in blue, or 3 in orange for different tests. Culture by Lowenstein-Jensen, culture by Midget, expert, combination of culture, and combination of expert and culture. And what I want to show you is that with a second sample, whatever testing you do, you get an incremental yield and then a small incremental yield with a third sample in orange there. So whether you do culture, combined culture, culture plus expert, you see that incremental yield with a second sample. And now with ultra, we have even a better ability to detect M. tuberculosis on induced sputum. And this is our data of ultra on a single induced sputum. And you can see the sensitivity has gone up to 75%, similar sensitivity in HIV infected and uninfected, and similar sensitivity in younger versus older children. Tanzanian study, a different study, around just over 200 children, a little older than our population, around 5 years, almost over 50% HIV infected. And again, the sensitivity of ultra was around 64% compared to 54% in expert, and the specificity was similar. So an increased sensitivity of ultra over expert. Now, to return to this theme of needing repeated samples in children, and let me show you the data that we have on using different specimens and their combinations. So this is a study that we did looking at ultra on a single nasopharyngeal aspirate, sensitivity of 46%, on induced sputum, as I've shown you, 74%. But look what happens when you combine these two. You get up to a sensitivity of 80%. What happens if you use 2 samples? If you combine 2 nasopharyngeal aspirates, you get up to a sensitivity of 54%. If you combine 2 nasopharyngeal aspirates and 1 induced sputum, you get up to a sensitivity of 88%. You are detecting almost 90% of children who have culture-confirmed disease. So this is amongst the highest sensitivity that has ever been reported. And this shows the theme that I've been saying over and over again, that in fact in children, if we want to get a confirmed microbiological diagnosis, it is likely that we're going to need repeated samples. Either combinations of 2 nasopharyngeal aspirates and an induced sputum, or 2 induced sputum. And why is this? And I think this is because children have such low bacillary loads. And if you look at why ultra has an increased sensitivity compared to expert, you can see that the bacterial load is very, very low. If you look at the quantitative results, the majority of children, in fact, have trace positive or very low amongst the ultra positives. And you'll remember that this trace was added to Ultra, and so you can appreciate why Ultra detects so many more cases compared to Expert, and you can also appreciate why it's been so difficult to microbiologically confirm TB in children, because they are going to be smear negative, and what would need a very sensitive test to detect small numbers of bacilli. What about urine? And here we've seen an improved Fuji-Lam test and a Lear-Lam. And so here is our data for confirmed, unconfirmed, and unlikely TB for Fuji-Lam and a Lear. And just so that you can eyeball this, you can see it looks quite good if you look at the confirmed cases, but look at the problem here. Children without TB, a large proportion are testing positive for a Lear-Lam, and similarly for the unconfirmed cases, and you don't know whether these are true positives or false positives. If we look at the sensitivity and the specificity here, and this is for Silveramp, the improved Fuji-Lam, overall, unfortunately, Fuji-Lam sensitivity only 42%, a Lear-Lam only 50%. And low specificity with a Lear-Lam. I showed you all those false positives in those children who did not have TB. Fuji-Lam has better specificity. But then, as in adults, you'll know that in adults, this test is positioned for HIV-infected, severely immunocompromised adults. And it may be that in pediatrics, this is also the place of this test, because the sensitivity is much higher in HIV-infected children, a 60% sensitivity, and also much higher in malnourished children, 62%, at least for Fuji-Lam. And this is important because these are the exact children who are at risk for severe disease and for rapid deterioration. And so this may offer a rapid point-of-care test in this subgroup of patients to detect TB. Compare this to the sensitivity of Expert, 74% on induced sputum. It's still a better test. Now, there are some promising biomarkers, but the field has been quite limited in that samples are not easily obtainable in children. Even urine, for example, is not that easily obtainable. I showed you that a Lear-Lam has many false positives. And part of the reason is we think that those are samples that were collected by bag and that there's contamination from skin flora that is giving a false positive. Similarly, we think stool is a simple sample to collect from children, but it turns out that it's actually not so simple. You need quite a large volume of, you need quite a large volume of stool, quite a large amount of grams, and the processing is not that easy in the lab in order to perform ultra on it. In addition, many of these studies have been done in small populations and haven't been validated across different settings. Some of them have low potential for point-of-care testing, for example, the transcriptomic tests, and we are not seeing a pipeline of development into point-of-care testing. And I just want to remind you of what the WHO recommendations are for a diagnostic test. For a triage test, you should have 90% sensitivity and 70% specificity, whereas for a definitive diagnostic test, around 66% sensitivity and 98% specificity. And so here are some of the promising biomarkers. This, for example, is a transcriptomic 51 gene gene expression array associated with TB, reported to have high sensitivity and specificity, 83% sensitivity, 84% specificity. Again, this doesn't meet the WHO criteria for a triage or diagnostic test, and is certainly not suitable for a point-of-care test. However, there have been ongoing studies, ongoing studies developing a 5 and 6 gene signature. In fact, there's a microarray 5 gene signature in adults that looks quite promising, and ongoing studies that we and others are doing to develop a transcriptomic test that has fewer genes, 5 to 6 genes, and that may have potential for translation into a point-of-care test. TAM-TB, which tests for TB-specific T cells, also done in Tanzania, again reported to have high sensitivity and specificity, but small sample size, very small study. Again, ongoing studies. This looks very promising, but we need to see bigger studies, and we need to see this as a point-of-care test. And then metabolomics, again, sort of moderate sensitivity and specificity. You'll see how small these numbers are, and largely in adults. Again, we need bigger studies. We need studies in children, and we need to see if these do meet WHO criteria, that there is move to translate them into a point-of-care test. So let me leave you with some key messages. I think there is still a high burden of unrecognized childhood TB, particularly in the context of acute pneumonia in children. We can make a microbiologic diagnosis effectively in children, and especially with the advent of Expert and Expert Ultra. This has been an important advance, and that has strengthened the ability to make a rapid microbiologic diagnosis, as well as, and this is not an area that I really spoke about, but detect rifampicin resistance and initiate appropriate therapy very quickly. Of all the new samples, induced sputum still provides the highest yield in terms of sensitivity. It's feasible, it can be done as an outpatient, and it is really possible in majority of children. It doesn't require sophisticated testing. It's really just nebulization, and then the child, nebulization with hypertonic saline, and then the child either is able to cough out a sample, or there's some suctioning to obtain it. For children, unlike in adults, we need repeated or combination of samples. I've said a lot about that, either 2 induced sputums or 2 nasopharyngeal aspirates, or with or without an induced sputum. And there are several promising biomarkers, but we need further studies on those in children. And I think this slogan for access to rapid diagnostic testing for all, but particularly for children, and that we advocate loudly for children to be included in new diagnostics, and we strengthen TB programs to detect many missed cases of childhood TB that we thank you very much. Some of the data I've shown is from some of our TB studies with a wide number of funders, just to acknowledge those funders, and also all the people, collaborators, and the wonderful teams that I'm fortunate to work with. Thank you. Sorry, it seems that came from a video that I'd done before, but thank you very much, and thank you for listening.